Spine surgery live broadcasted for you to watch. Our patient has two herniated and degenerated discs, one at L4-5 and the other at L5-S1. She's having back pain and pain into the right side. Our patient is here in the operating room. She's awake and listening in. We're going to put her to sleep shortly, but I'm not ready for her to go to sleep just yet. I do need my patient's help during the Deuk laser disc repair. The Deuk laser disc repair is an endoscopic spine surgery. The purpose is to repair the annular tear in the back of the disc to cure back or neck pain or thoracic pain, as well as radicular symptoms. All right. Good morning. Can you hear me?
Yeah.
All right, we're going to get started, okay? Now, you might feel a little poke, some pain. If you do, just say ouch, and I'll give you some more numbing medicine. All right, I need your help, though, in the beginning. You got it? Deal? And don't move around too much, okay? Try to lay still. Are you comfortable where you are?
Yeah.
All right. We're going to put you to sleep as soon as I'm safely where we need to be, okay? All right. I need your help in the beginning. Okay, so let's try to keep her blood pressure down. That's fine. My goal is 110 systolic. So, all right. I'm going to give you a little numbing medicine, okay? You'll feel a little stick and burn. That's normal to feel. That's just my hand probing around. I'm looking, just kind of feeling your anatomy. I'm feeling the iliac crest. A little stick and burn. This is normal. Don't get upset about it. Does that hurt? Not too bad? She's nice. Is she a little bit sedated?
Just a little bit.
Yeah, it's perfect. Yeah, it's really nice. Yeah. So she's responsive to pain, I hope, but she's calm. She's not trying to get off the table. You know, it's a tough balance in the beginning. I need them to, as I'm accessing the disc through the foramen, the nerve root's there. So I don't want to stick the root. If I go through the root and I don't know it, then we could do some damage. So I've never had that happen. That's because the patients are awake and they're able to say, ow, I feel the pain down my leg. So then I redirect the needle. All right, I injected 7 cc's of local. We're going to get started, okay? Remember our deal. If it hurts, just say ouch, and I'll give you some more medication, okay? Shot. All right, so I'm going to aim for L5-S1 first, and I'm probably going to have to redirect and reposition, but you know, it's a start. Shot. You feel something there? Lateral. Where do you feel that? Your back? So what I'm most interested in is their pain shooting down her leg. Now, sometimes we'll get a facet reaction where they'll get pain in their thigh down to the knee, but not past the knee. I'm more interested in pain shooting down all the way down the leg, into the calf, the foot. It rarely happens. Okay, so we need to get a better picture of 5-1. I think it needs to be magged in, and then we can play with the wag a little bit. You're not that far off. You can see the iliac crest is actually passing through L5, right by the pedicle. So I think we need to go further south a little bit. Are you comfortable? So now I'm not repositioning the needle because there's no point in using the needle to navigate to where I need to go until I know that the X-ray picture is reliable. Okay, and what does that mean? It means that I have to know that the relationship between the needle and the disc is a reliable relationship as I pass the needle down to the disc. Okay? So that's getting better. You see there's a weird shadow on the pedicle? That's your arc. Try the other way. think that might be better. What do you think? I think that's better. I think that's better. I think you need to go a little bit more, just the tiniest bit more. So why would it be so difficult to line the fluoro up? Actually, I can see the whole pedicle right there. That's worse. So we need to go the other way. Why would we need to line up the spine? Why is it so difficult? Why do we need to change the angle? I would go a little more, the same direction you're heading now. We need to, because we got to know that there's a reliable anatomy that we're using to navigate. You got to go more. That's not enough. I'll tell you when it's enough. All right, so that looks better. The real issue is maybe a little bit of wag. So I'm going to be going basically from the outside world into the disc, right where the annular tear is in the back of the disc. No, it's worse. You see the double shadow of the pedicles there? We want to get rid of that. You had it gone before you just changed whatever you changed. Yeah. So all right. So we're just standing here waiting for Jordan to get this right. Hey, can you help Jordan get 5-1 lined up, please? All right, so for those of you watching, the importance of getting the anatomy proper on the fluoro it cannot be overstated. If I don't know where the holes are, where the bones are, where the facet joints are, where the framing is, based on the x-ray pictures that are being taken, then I cannot safely navigate into the disc with the needle. So the first thing we have to do is get the fluoro shots reliable. And what you want is you want the end plates of the disc that you're treating. You want the end plate of the bone above and below to be lined up parallel to the fluoro. And you don't want any rotation. You don't want any what's called wag. You want the pedicles lined up. You want the end plates lined up so that you have a true lateral view of the disc. It's called a true lateral view. And the problem is these patients, they get scoliosis as they get older. And so their spines twist. And as a result of that twisting, then you can't just put the fluoro in a lateral view and expect to see the lateral view on the spine. The spine is now shifted from a true lateral into an off lateral. So you have to change the three-dimensional positioning of the fluoro machine. I think the patient is glowing green at this point. All right. You guys doing all right? You need some help? You see this shadow right there, that line? And then the other one, they should be lined up. You see the pedicle right there? That should be lined up. It should be a true lateral. It's rotated. Monica, can you help out? The end plates look pretty good. That's the wrong direction. You guys still struggling over there? So Monica, you see the double shadow of the pedicle right there and right there? That should be lined up to there. At least more closely lined up. So that's a rotational issue, not a WAG issue. Do you understand? And you may not get it perfect because you may lose the sacrum. And the same thing's happening at the sacrum level, by the way. I think that's better. That's better. I know we're close. I wonder if we can't make it better there. How many seconds of fluoro have we got used? 14 seconds. Yeah. I don't know. Huh? Was that better before? I think it was better before. All right, well, if you can clean that up, I still think we could do better than that. But unfortunately, the patient's anatomy is such that she's very rotated. All right, is that uncomfortable, Sean? Yeah.
Yes, it's uncomfortable, Jeanette?
Yeah, I think she said yes.
It's okay now, she said.
All right. Monica, we need to try to do better than that. That foramen is not looking open to me on the lateral view. I don't think we have a true lateral. I could be wrong, but I think we're close. You know, I might be able to make that work. I'm not sure.
That hurt her.
All right, let me give her some more numbing medicine. But the numbing medicine's not the solution because I'm close to the root, so I don't want to numb the root up. So I need something on your end to calm her down and settle her. Just lay still. You're fine, Sean.
Give you a little more medicine. A little more medicine to make it a little bit easier, okay? And have to give you a little bit more also.
Sean. 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 Yeah, there's definitely a rotational component. Sean? Is that better? Where do you feel that?
Where do you feel
AP.
that?
In your back or down your leg? Okay. All right. Now, before surgery today, did you have right leg pain? Uh-huh. Let's go back to a lateral. You can see the scoliosis. Shot. Before today's surgery, was your right leg pain there all the time or just sometimes?
Sometimes.
When you were up walking?
Yeah.
All right. I'm sorry you're uncomfortable. We're going to be able to put you to sleep soon, okay? Where do you feel that, Sean? Where do you feel that? In your back?
Yeah.
All right, you're doing great. We're almost done.
Okay.
I promise. All right. So we're in, which is like almost impossible to do, but we finally got a decent enough x-ray. Let's try to do 4-5. It's going to be easier because it's not as collapsed, okay? No, yeah, no, good now. We're good now. So I do need her awake. But I need her awake in about 5 minutes. So whatever. And I'll tell you, that way we can work nicely together. So L5-S1 transforaminal endoscopic surgery. Virtually no surgeons do it except for me here at Deuk Spine. Why? Because it's really hard to get in at L5-S1. And what I mean by that is the iliac crest blocks access. So there's a very small little window, just a little bit wider than the needle, of getting in. But I've done thousands of these, and I've gotten very comfortable doing it. But the few endoscopic transforaminal surgeons that I know of for the lumbar spine in the world, many of them won't even try L5-S1. They do something interlaminar rather than transforaminal, okay? There's nothing wrong with going transforaminal. Literally, I had to back out and not access maybe 1 in 100, maybe 1 in 200, somewhere in that number, that I've had to abort L5-S1 because of anatomical constraints that I couldn't get in. But the vast majority of the surgeries, I've been able to do L5-S1. So my advice is, if you want to get into endoscopic surgery, spine surgery, don't just give up on L5-S1 before you even try. If you have good technique, then you can do it. All right. So let's try to line up the pedicle of 4. There's a double shadow, so that's a wag factor that we need to fix. Plus, I can't see the end plate straight on. I understand there's some scoliosis at 4-5. You can see the needle at 5-1. We're in the disc space. Now, I think that's better. That looks good. But look at the facet joint at 4-5. It's just so wide. Probably an effusion. I think that looks good. Monica, what do you say? All right. We know there's a good size herniation at 4-5. And the 5-1 is a more collapsed disc space. You're doing great, Sean. So I'm a little lower than I need to be. I apologize. You're doing great, Sean. All right, so I'm encountering the facet. Num num. I'm going to give the patient a little more numbing medicine to ease the discomfort. I've just given a couple of cc's, that's all. And I'll tell you, after doing these surgeries for almost 16 years now, there's a real difference in tolerance to getting down to the spine. I think part of it is anesthesia. I think the other part is just patient. Some patients have a higher kind of acute pain tolerance. Remember, your acute pain pathways are shot different than your chronic pain pathways. So people who have shot, they may be wired differently basically for acute pain versus chronic pain. Shot? And when I first started doing these surgeries, I would access one disc at a time, and I'd wake the patient up and then put the next needle in. And then I realized that was not the right way to do it, so I changed the way I did it. You okay, Sean? You're doing great, by the way. We're almost done. That's nice and low in the foramen. That's where you want to be. There's no nerve root there. I can feel the herniation. So, are you comfortable?
We have a question.
You have a question. Go ahead. All right.
One of our viewers from YouTube is wondering, do I see severe spondylolisthesis on the MRI?
There is a spondylolisthesis above the needle at L3-4, yes. It's not severe. It's grade 1. Yeah, and there's also spondylolisthesis at L2-3. So the two discs above what I'm treating have spondylolisthesis. Great point. So we're going to fix the pain without treating the spondylolisthesis at those levels. And that just goes to prove that spondylolisthesis is not the cause of pain. It's the disc itself that's the cause of pain. And in this case, 2, 3, and 3, 4 rarely cause pain. So we're not treating them. Her pain is lower. All right, are you comfortable?
Yeah,
A little bit? All right. We're going to perform a discogram.
oh,
You hear that, folks? How bad is that on a scale of 1 to 10? How bad did that get?
5, 6,
The highest it went. I want to know the highest it went.
oh, 6, 7.
7. The highest it went was a 7.
Yeah. Oh,
That's only a 7 or what?
oh,
I need to know. I need a number.
9.
A 9. Was that where you typically have pain? Is that where you typically get your back pain?
Yeah.
All right. So, folks, I don't know if you could hear her answers, but that was a 9 out of 10. Okay. She was basically coming off the table. All right. She arched her back, which maybe you saw. She grunted, said, "Oh!" She was in pain. How is that possible? That's possible because the L5-S1 disc is the cause of her pain. She has no spondylolisthesis at L5-S1. None. She has spondylolisthesis at 2, 3, 3, 4, arguably a little bit at 4, 5, anterolisthesis. But she has no spondy at 5-1, and yet she has pain from the 5-1 disc, and that's her typical back pain she gets. You understand? We call that concordant pain in the business. It means that's the patient's typical pain. So some of you who don't know discography may be thinking, well, of course, you injected this liquid into her disc, right? Anybody's going to have pain. No, absolutely not. A non-painful disc will not evoke a painful response when you do a discogram. As a matter of fact, it's an incredibly reliable tool. Test. It's not a treatment, it's a test. So I'm injecting a blue dye, plus I'm injecting Omnipaque, which is radiopaque and allows us to see the inside of the disc. And what you can see is the tears in the disc are so bad in the annulus, the tears are so big and so bad and so widespread that all the dye is leaking out immediately. Normally the dye stays in the disc for a little while. Are you comfortable?
I'm okay.
All right, I'm sorry about that. I'm sorry about this too.
Oh,
How bad is that on a scale of 1 to 10?
10.
A 10. All right. So there's L4-5. We just did the discogram at 4-5. And if you look at the back of the disc where the dye is, that black dye, right where the needle and the dye meet, there's a tear there. It's a grade 4 tear in the posterior annulus. That's where the pain comes from. Once again, that is my discovery at Deuk Spine Institute, first in the world to describe it. It is the posterior annulus tear and inflammation that causes the discogenic back pain. That most doctors don't even recognize that discs cause back pain. So we've got so far to go in medicine before we get everybody in the same boat understanding the causes of back pain. But the disc is definitely a cause of back pain, as you just saw. Okay? We are now ready to put this nice young lady to sleep. Okay? So take your time with the propofol. I'm going to be stimulating her in about 3 minutes, but I'll wait until you tell me you're ready. I want to start with 5-1.
You get you a little sleepy here, honey, okay?
So, ma'am, will you count out loud for me from 1 to 100, okay? Just start counting out loud. I want to see you count from 1 to 100 out loud. Go ahead. Keep going. You're doing great. All right. So we're going to start at L5-S1. It's the harder one to do. Keep going. You're doing great. Sean? So I'm going to take I've got the guide wire in at 5-1. I'm going to take the needle out. And we're going to use this guide wire to access the disc space through the soft tissue. And we know we're in a safe place because I know the path. Skin, fat, fascia, right there. Nobody likes the fascia. Fascia is innervated. The lumbosacral fascia has nerve fibers in it, so when you go through it, it can be uncomfortable. You okay? You're doing great. Perfect. So she's in La La Land. She stopped counting. We know she's in La La Land because she stopped counting. And I'm sure the anesthesiologist knows by other things, but that's how I know she's in La La Land. All good. Perfect. All right, so we're about to stimulate her, okay? Here we go. So this is stimulating because we're going to pass through the annulus, which is the painful part of the disc. Shot? All right. Now, the more awake the patient is, the harder it is for me to do this because they start to tighten up. Shot? I know it looks brutal, trust me. But I can't do it any other way. Shot? Let me just see where we are. I don't think we're in far enough yet. Shot? So I can tell you right now, this disc has virtually no disc left. It's quite literally 95% gone. So why are we treating it? Because there's a little piece of tissue in the back corner in the annulus that is causing her pain. And that piece of tissue, shot, well, it has what's called granulation tissue on it. Shot? Yeah. Perfect. All right. Let's get that out. And that granulation tissue is there because of chronic inflammation, okay? So when she injured the L5-S1 disc many years ago, she tore the annulus. The annulus quite literally tore, as it does for every single disc herniation in the world. And then after the annulus tore, some of the jelly from the center of the disc, the nucleus pulposus, it squeezed out through the tear and wedged itself into that tear in the back of the disc. And it just sat there for years, causing inflammation. Hold on, let's pull the fluoro out, please. Yeah, causing inflammation. Hey, Luis.
Yes, sir.
We need to buy some more of these supplies. I want to, as you're preparing the case, I want to start looking at our inventory.
Not a problem.
And we need to make some purchases.
Yes, sir.
Okay?
I will do that.
All right. So, are we switching over to the endoscopic view? So at this point, folks, we are in the disc, in the spine, and we're about to start the Deuk laser disc repair. What is the Deuk laser disc repair? It is a surgery that I pioneered and discovered that's different than any other surgery in the world. And the focus of the Deuk laser disc repair is something called the annular debridement. Annular debridement. And in surgery, debridement means when you clean up damaged tissue. You clean it up surgically. You clean it up by removing the damaged parts of the tissue that are not healable, basically. They can't heal themselves. They're full of scar tissue and little nerve fibers and blood vessels that are abnormal, and they're just causing pain and dysfunction of the joint. So I'm going in there to basically debride the annular tear right where the pain is coming from, right where the inflammation is. Okay? Little bit of blood clot. And remember, we're inside the disc at L5-S1. And because this patient has, this disc is so collapsed that it's really going to be just end plate, mostly end plates that we see. And the end plates are basically the bones on either side of the disc, okay? Can I see that last fluoro picture? That's it there? Okay, good. So I'm going to work my way back out of the disc towards the where the annulus tear is. Okay. Laser. And the reason why we have a little bit of bleeding is it's bleeding from the end plate. Very common when you have very little disc left, because there's a little bit of trauma to the end plate coming in. Stand by. And I apologize, this disc is going to be hard for you guys to see what I'm doing. Fortunately, I've done this a couple of times, and I know the anatomy pretty well. But there's not going to be, there's a little piece of herniation. Take that. There's not going to be an abundance of herniated disc in this particular disc because there's not much disc that herniated. It's just quite literally a small amount. There's a piece I just gave Luis. And so it's just in the right spot. You know what I mean? Like in neurosurgery, we often see little things that are abnormal in the body. They're tiny, but they're in just the right spot to cause lots of symptoms. For example, a small brain tumor, if it's located in the brainstem, the part of the brain where there's so many nerves, pathways, and neurons and nuclei, that if it's there, it's going to have drastic effects on the patient, symptom-wise. Well, they could lose the ability to swallow. They lose the ability to talk. All right? They can lose the ability to move their eyes at all. They can get locked in. It's called locked-in syndrome. Okay? So we know that in the human body that a lesion or an abnormal collection of tissue in just the right spot, can be a small piece of real estate, can cause really bad symptoms for the patient. And that's exactly what this issue is that we're dealing with right here. This is a very small part of the disc. It's literally the back of the disc. Stand by, laser. And it's an area of the disc that is, by volume of the disc, it represents quite literally 2%. Right there, you see it? That little red area is pink granulation tissue in the posterior annulus. Okay? See that trick that I use? I use the pituitary to stop the flow of blood and fluids, and that gave me just a little picture, a brief moment to see what my target is. Okay? And I'm going to bring the laser in and zap it. So that little nest, that little grape of granulation tissue in the posterior annulus is the cause of the back pain when you have discogenic pain, which we just confirmed that she did by the discogram that you witnessed earlier. If you don't remember it, rewind, go back and see it. So I confirmed that her pain is indeed coming from this disc and the disc above this, the L4-5. And then where is it coming from? I already know. Okay? I already know where the pain is coming from because anatomically I've already discovered the source of the pain years ago when I started developing this procedure to target the source of pain in a herniated disc is always the posterior annulus, posterolateral annulus, which is where we are right now. Okay? So I'm almost done with the L5-S1. There wasn't much to fix. Everyone thinks that, oh, you have to have a big herniation to have big symptoms. No, that is 100% wrong. Do not believe that. It is not true. A small lesion in the right spot will cause massive symptoms for the patient. And that's what we're seeing. A tiny little tear, literally a few millimeters long, causing horrible pain. And I am the one to discover that, and I'm trying to spread the word so people understand it, so we don't have to have people living in back pain, neck pain, thoracic pain anymore. We can fix these problems. And again, I apologize for the poor visibility for the viewers. I can't control the bleeding. I mean, I don't mean that, please don't take that out of context. Of course I can control bleeding, but I can't stop this little bit of bleeding we're getting that's obscuring your view. I'll bring in the pituitary again so you can have a better view. This bleeding you're seeing is literally, if you do diabetes glucose checks on your finger, it's the same amount of bleeding, okay? It's tiny. It's just little wisps. You can almost see individual red blood cells. So here's the back of the disc. Okay, see the end plates, the two pink things, left and right? That over there is the end plate of S1, and that up there is the end plate of L5, and you can see the cartilage is pretty much gone. And just the remains of the disc back here is minimal. I'm taking out little pieces of herniation. These are all pieces of herniated disc that are causing pain. All right, so that said, we are just about done. I'm going to pull my retractor back a tiny bit more, and this should be the last of it. And then we'll be done with the L5-S1. We can move on to 4-5. See the pink coloration? That's where the pain fibers are. This is, again, the annular tear, and the Deuk laser disc repair procedure is the only surgery in the world that debrides the annular tear. There's no other surgery that does it. We're the first to discover this is where the pain is. Okay? You know the movie Pacific Rim? If you don't know the movie Pacific Rim, go watch it. So there are these things called the kaiju monsters. They come out of the ocean, but nobody really knew where they came from until they discovered that there was a connection between our world and the ocean, a very specific spot that these monsters were coming out of. Think of this annular tear as being that spot. It doesn't move, it doesn't change, it's always the same, and this is where all the monsters of pain come from. And I'm here fighting these monsters with a laser. And we're getting rid of the port. I forgot what they called the port. Anybody remember what they called that port? Where the monsters came out of? Anybody? Come on, someone impress me. Huh?
That movie sounds too scary for me.
You've never seen Pacific Rim?
No,
Great movie. Oh, it's a great movie. It's not scary. It's a little scary, but not bad. It's a great movie. Great, not the second one. The second one sucked. Second one sucked. The first one was good. Really good. Really, really one of the best movies made in the last 10 years. So there's a place that they come out of. What is it called, Sean?
Is it the breach?
The breach. That's what they call it. The breach. All right. This is the breach, folks. It's the same. It's the annular tear. It's a breach. There's a breach in the annulus where the jelly and the discs have come out. The nucleus has come out and squeezed through that tear, just like the monsters squeeze out of the breach and wreak havoc on the earth, okay? So this is identical. We have a breach through the annulus. We have the monsters of pain coming out to affect the legs, the back, causing back pain, leg pain. And I'm here trying to close the breach. All right, first I have to kill all the monsters, and then the breach will close. You like that analogy? That's the first time I've used that analogy, but I think I have to use it some more. It's important because everyone's wondering where are these monsters coming from. They're coming from one spot. Where's the back pain coming from? It's coming from one spot. It's a breach. It's a place where bad things come out and enter your life, just like the monsters came out and entered the world and created problems for everybody, killing people. So we're here trying to close the breach. Okay? I should get some movie credits for that. Maybe royalties on the movie. People are going to start watching it now. All right, but the breach is the best way to describe the annular tear. Okay? And it's one specific place. Posterior, lateral. Right where you can access the disc through the foramen. That's why this surgery is so amazing. There's no bone removed from the spine. We are not doing a laminectomy. We're not doing a microdiscectomy. All those traditional spine surgeries, laminectomy, microdiscectomy, foraminotomy, partial facetectomy, all of those procedures involve destroying your spine to get to the herniation. And even then, they don't fix the back pain. They only treat leg symptoms. So here we are curing back pain and leg symptoms without drilling holes in the spine, okay? Very important distinction. So this is a better surgery. It's less invasive. Yeah, we're right in the most painful part of the disc. That's why she's responding. I can feel her twitching a little bit. All right, pretty much done. I want to look at my work. I'll bring my pituitary back in and check it out. Looking pretty good. A little bit of crabby disc right there. Take. Let me just look again. So this is again 5-1, totally collapsed. Most doctors would have written this level off and they wouldn't have treated it because they don't understand the pathophysiology of back pain. Okay? If you ignore reality, laser on. then reality will ignore your treatment. Okay. These treatments are based on having a functional understanding about the pathophysiology of pain. We're done at this level. I may be able to show you the nerve root. Let's just take a quick look, see if I can show you the right L5 nerve root since we're on the right side. It's going to be just north of us. Didn't mean for that guy to slide in, but sometimes it's buried in fat. Yeah, it's still buried in fat. Can't show it to you. But that's the disc down there. We just finished removing the herniation. And I debrided the annular tear, and we're done. Let me just get the liquid out. Oh, that worked nicely that time. Remember the other day it wasn't working so well? Was there a reason for that?
Maybe the suction tool is not
Okay, so we're done with L5-S1. I'm going to show you, if you guys want to take a look here. We need some light here. Can you see, Sean?
Yes, we can.
All right. So this is her back. This is the right flank area. Her head is over here. We have a 7mm incision. That's where we're doing both disc repairs through that incision. I'm going to take the tube out. The whole surgery is done through a tubular retractor. It's a real surgery. It's not a percutaneous procedure. So this is a real... Percutaneous procedures are those that are done through the skin with a needle. And this is not a percutaneous procedure. This is done as a real surgery. Let's go back to a lateral fluoro view. We're going to get the L4-5 done next. Now look, I'm actually putting pressure on the paraspinous muscle right here because remember, we went through the muscle. We didn't cut it or damage it. We actually dilated it using the dilator. Let's show them the tip of the dilator. So, time for a little lesson. Okay? I'll teach you the sequence here. It's funny because I've been teaching this surgery now. I've shown literally hundreds and hundreds of these surgeries over the internet free for the last, 7 years, 8 years now? Where's the needle? That's fine. All right. Let's move that. Okay, so here's the needle. Can you see this okay, Sean? How
Yes, we
well can
can.
you see it, all right?
Very well.
So remember, I put the needle in, okay? Then I took a guide wire. I ran it down the needle. Okay, there's the tip of the guide wire. And it's sitting right in the annular tear and the herniation. Then I take the needle out and I run the dilator. Now look at the dilator. See the tip? The tip of the dilator is tapered like a pencil. It's very delicate and gentle on any tissue it passes through. So I'm going to run the dilator down the guide wire. The purpose of the guide wire is to make sure the dilator doesn't go somewhere it's not supposed to go, and like into a nerve or a blood vessel and hurt the patient. So as I come down then, and I pass it through the foramen into the disc, and then I take the guide wire out, and then I put the tubular retractor. You see the tubular retractor? This is like I call it the McDonald's shake straw. All right? But I had a shake the other day in Fort Lauderdale. It was really good. Good chocolate shake. Okay? So I may have to call it a different name. That was a Nitro Ice Cream Shop, it was called. Something like Nitro Ice Cream Shop. So we'll call it the Nitro Ice Cream Shop of Fort Lauderdale Chocolate Shake Straw. So we come down into the disc, and then I take the dilator out. And now look at this. I got this window right here. I can do the whole surgery. I'm inside the disc, and we're in there with the scope, and I can see everything. Okay? So let's take you through it in real time. Our needle is inside the disc. We get rid of the stylet. We go down with a guide wire. I know I can feel the disc right there. Then we get an x-ray picture to make sure, yep, perfect. Then I take the needle out. Yeah, and this is the Deuk laser disc repair, endoscopic surgery. Please don't try to do this at home without proper training. Proper training requires a fellowship with me, and that fellowship is a year long. I train surgeons to do this procedure. Shot. Now you can see the tip of the dilator is now at the back of the disc. Our anesthesiologist has done a remarkable job of keeping the patient comfortable. And now I'm going to go through the annulus, which is the more painful part. okay? I can feel the dilator going in. Now I'm watching the guide wire. I don't want it to advance. You don't want it going past the front of the disc. Shot. And once you're seated into the disc well, you don't need the guide wire anymore, okay? You don't need that guide wire anymore. So I got to feel, am I in the disc? It feels pretty good. Take the guide wire out, and I'm going to advance. Shot, and that's perfect. So one more whack for good measure. Now look, very minimal blood loss. We've lost literally, by the end of the surgery, 2 or 3 milliliters of blood. Have you seen open spine surgery done? She tells me all she does is do spine surgery anesthesia. Have you ever seen something so minimally invasive before? Never. And the patient's comfortable. There's no open incision to heal from. It's a tiny little 7 millimeter incision. It's all done endoscopically. This is the most advanced spine surgery in the world for treating herniated disc, spinal stenosis, radiculopathy, and of course, if you think about it philosophically, to treat scoliosis and listhesis, because even though this patient has listhesis and scoliosis, we're not actually treating the listhesis or scoliosis, okay? And we're still going to cure their pain. Why? Because it's not the twisted bones that cause pain. It's not the listhesis that causes pain. It's the disc that causes pain. And that's why we broadcast this, because we're tired of hearing all these stupid things that people do on people's spines that are unnecessary, highly invasive, when all you need to do is fix the disc tear. Again, Deuk laser disc repair, that's the only procedure in the world, and the first to be published back in 2012. That was 9 years ago we first published this surgery about repairing the annular tear to treat pain. So, unfortunately, surgeons haven't really caught on yet. They're still doing fusion surgery, screws and rods. I still do them occasionally because some patients want that, not because they don't know about the laser, but because their insurance benefits will more likely cover fusions than they will the laser surgery for certain insurances. So they don't want to take the chance of the procedure not being covered. Okay, we're inside the disc at 4-5, and I'm going to pull it back, and there's the tear right there. You all remember why there's blue dye, right? That's the blue dye that I injected. That's not natural. And it's a little bit blurry, so I'm going to try to clean it up. Let's see if I can make it better.
We have a question.
Yes, I'll take the question.
A viewer from YouTube is wondering, are there any kinds of herniations that the laser won't work on?
Are there any kind of herniations the laser won't work on? Now, a little tongue-in-cheek, a little coyness. Don't take it the wrong way, but we need some humor. It won't work for, like, inguinal herniations or umbilical herniations. Okay, so for spine herniations, herniated discs in the spine, it works on every single one of them, 100%. It won't work on, like, if your intestine is herniating out through your inguinal canal. All right, joking, of course. It won't work for, like, a cerebellar herniation or a cerebral herniation, a tentorial herniation. Her brain is herniating in the skull. So, yes, it works for all spinal herniations, thoracic, cervical, and lumbar. We started doing thoracic herniations with the Deuk laser disc repair last year, 2020. That was the first time I've ever done it. I had some bold patients who boldly went where no man has gone before, no man or woman has gone before. By the way, that's a piece of herniated nucleus pulposus right there that I shoved back into the disc when I put the dilator in, and now I'm fetching it out. That's what a herniated disc looks like right there, okay? I'll give that to Luis. Don't say I never give you anything. I'm a very generous employer. So the Deuk laser disc repair procedure will work on any disc herniation in the spine. Okay? It just doesn't work on extraspinal herniations. That's a great question. Keep them coming, folks. We love questions. If you don't ask questions, I start talking about weird stuff. I warned you. All right. All right. Okay. So, what do I hate the most? I hate employees that walk off their job when they're taking care of patients. Why does this come up? I'll make you famous. We had an employee, his name was Drazi, work comp coordinator, walked off the job, lied to us, told us he had COVID. Why? Because the job is hard. You know, neurosurgery is hard, folks. I could have walked off the job 1,000 times. I wanted to, but I didn't. It's called dedication. What are you dedicated to? You're dedicated in the end to whatever you're dedicated to. In my case, I'm dedicated to helping people that are suffering and in pain. So whatever it is you're passionate about in life, you should be dedicated to that. And you shouldn't go and lie to people and tell them you're going to take a job and you're going to commit yourself and dedicate yourself and then walk off the job because it gets hard. You know? Especially when they tell you it's hard ahead of time before you take the job. So there it is. I'm very upset. And unfortunately, it's not the only time it's happened. And I'm not the only employer it happens to. But, folks, these are time capsules. Anybody know what a time capsule is? In the old days, before there were computers, people used to take things from their time period and they would put it into a container and they would bury it for 10, 20, 30, 50, 100 years. Sometimes they ship it out into space. And basically, it's a snapshot of things that are important at that time. You know? For example, like when I grew up, rock and roll was important. I never thought rock and roll would disappear. My God, it's gone. Payphones, gone. Right? There's so many things that were staple part of our life that are now gone. And these videos are my time capsule because I'm the one paying for them. So I get to say what I want, do what I want. So I'm trying to capture some of the contemporary issues of today that plague our business or successes of our business. But to keep it interesting, we got to talk about the failures too, right? Because life isn't always winning. Life is about winning and losing, and when you lose, figure out why you lost and try to fix it and make it better. And I just don't know how to make certain things better. You know, for those of you wondering, I founded Deuk Spine Institute, had a lot of help, obviously, from my wife and really good employees over the years, but I was never, in my opinion, cut out to be a CEO of a company. I'm just a guy who figured out how to fix back and neck pain, and that's what I really enjoy doing the most. I enjoy curing pain, solving and curing. And we've been able to do that now successfully over and over and over again in our patients that come treat here. And we now know the causes of back pain, all of them. There aren't that many, and we know how to fix them. And we've been fixing them literally, reliably, for years and years and years now. Unfortunately, we're in an area of the world that, and a time of the world where the ability to disseminate knowledge and information is difficult. It always has been difficult, let's face it, but it's become even more difficult because there are a lot of forces that are working against us. For example, this surgery you're watching does not use metal implants. So the companies that manufacture implants, they're very powerful multi-billion-dollar companies. They don't want this surgery getting out. And I've gone to my American Association of Neurological Surgeons years ago and tried to spread the word about this procedure. And once they saw that it does not involve metal implants or biological implants, they got very upset and did not want the rest of the world to know about it because they were making so much money on implants. They're working for the implant companies. Just take a look at surgeons what's called a disclosure. You'll see many spine surgeons, neurosurgeons, orthopedic surgeons are on the payroll of the implant companies. They make a lot of easy money, millions of dollars many times, just being a consultant, what's called a consultant, which means they don't really do anything. They just get a paycheck. And all they do is promote the implants. And so I have the implant companies who don't want this surgery being known about because there's no implants for them to make money on. It's a natural repair of the disc. It's the most advanced disc repair in the world. The other people who don't want this surgery being known about and disseminated are the insurance companies. They don't want to pay for something like this because everyone's going to want this surgery when they find out that it actually works and cures pain. And so then they're going to have to pay more money. Insurance companies aren't here to pay money. They're here to make money. They've just tricked people into believing that they're there caring about them and to pay their bills and denying things because they're working in the best interest of the patient, but they're not. So we have the two of the most powerful industries in the world, the medical device industry and the insurance company industry, all trying to keep this surgery you're watching right now from becoming widespread because they don't want the costs or the loss of business that they would get as a result of everyone knowing about it. So I decided years ago that I was going to let the world know directly because the people who are responsible, the people who should be disseminating this knowledge, refuse to do their job. And that's not going to stop me or get in my way of getting the truth out. So that's why we broadcast. We broadcast because we want the world to know the truth, because people should know the truth. They should know they have a better option than what's being offered to them. That there's an actual motivation behind them not knowing about this surgery, that the insurance companies and the implant companies are working together, collaborating basically to prevent the spread of knowledge about this procedure and its effectiveness. Okay, this is an outpatient surgery you're watching. This patient's going to go home in about, I'm going to be done in about 3 minutes, doctor.
Okay, thank you.
And in 3 minutes we're going to pull this tube out and put a Band-Aid on. Okay, and this patient will literally walk out of here in an hour, as every other one of the 1,200 that I've done over the last 15 years have done. By the way, the fibers you're seeing are the posterior longitudinal ligament fibers. I'm just about done with this herniation. This is the L4-5 herniation, by the way, on the right side. And hopefully we can see a nerve root this time and not just a bunch of fat in the foramen. Okay? But this is lateral. This is all herniation that's lateral herniation in the foramen, extraforaminal. That's the annular tear right there, the white stuff. I'm cleaning it all up, letting it heal. That's all it takes, folks. Just coming in here and debriding the annulus, getting rid of the interposed nuclear material that's stuck inside the annular fibers that won't let the annulus heal. And if you just do this to your patients with a herniated disc and back pain, neck pain, thoracic pain, whichever one it is, then you can cure their pain. It's incredible. I don't know that this patient needs facets done.
Yes, sir.
No, I know we consented, but her pain response was so severe, I mean, we could probably do the facets another time if we need to. That's what I'm thinking. The discogram was positive to such an extent that I feel very comfortable that we can treat her facets if they need to be treated outpatient. Yeah, we don't need them. I don't want to have her do facets. She may be angry with me if I do that, but in the end, I don't want to put her through another procedure that I don't even know for sure that she's going to need. We kind of had her scheduled to do facet treatment, rhizotomy bilateral at L5-S1, just in case, you know, but I think her pain response was so strong with this disc that I feel very comfortable that this is the source of her back pain. So I'm going to cancel her facets. Maybe I'll live to regret it someday, but I always believe in doing minimal, what you need to do to get the job done. And right now, I'd say if her discogram was less strong, positive, then I would, yeah, we'd do the facets. But It's easy to get somebody in and do facets later if we need to. All right, that's it. See the fat in the epidural space right there? That's the end of the herniation. By the way, the blue fiber is the laser fiber, in case you were wondering. And the tip of it is a little piece of glass coming out. That is 0.5 millimeters wide, half a millimeter. And this is the last of the granulation tissue right here. See a little bone spur there? And all the white stuff is basically calcification. The golden stuff is calcification and scar tissue from chronic inflammation right here. See all the little golden nubbles? That's called dystrophic calcification. Your body's response to damaged tissue calcifies it. All right, let's see if we can see the nerve root. Again, fat and veins on top of the nerve root. Can't really see it, so that's fine. All right, laser off. We're done. Herniation is gone. I feel good. I'm going to shut this down. Any questions from our audience? Man, that sucks down good. Scope off.
No questions
right.
currently.
What?
No questions currently.
What? They know everything again? I'm getting tired of these audiences that know everything. All right, let's show the audience how we did this surgery. You want to take a look here, Sean? Let's get the light on here, please.
We see it.
All right, so the line here is the middle of her back. Her booty is here. Her back of her thoracic area is here. And this, everything was done through this one little cut. We've lost, I'd say, 5 mils of blood. So I'll call her EBL 5 mil. 5 mils is like nothing. 5 milliliters. Now, as people noted, she does have listhesis at other levels. And we're going to take a look at that later and see if that's affecting her. But when she came into my office and said, I have back pain, her back pain was right in here. Okay, and that's what we just fixed, this area. That's the butt crack. Her back pain is right above the butt crack. This is where 95% of patients have their back pain, the L4-5, L5-S1 region. Now the other two slippages are higher up, L2-3, L3-4, and she had no pain up there. So I'm not going to treat a structural abnormality of the spine that doesn't need to be treated. Okay? All right. We're going to check on her later, but that's the incision right here, folks. You see that? 7 millimeters. Great job, everybody. Luis? Nice work. I'll come and answer questions. Start typing them up, folks. We'll get your questions answered for you. Thanks, Monica. Good work, everyone. Nice job, doctor. Thank you. Ooh. That's interesting. I just splashed some water on my face from my gown. Yeah, I'm fine. No. It got on my forehead, but we're good. All right, I'll come answer questions, so please type them up.
All right, everyone. Thank you for joining us for the post-op Q&A. We have Dr. Deuk in the room with us now. We're going to switch to his face cam shortly. You'll be able to see him as he answers your questions. If you have any remaining, go ahead and type them in the chat now, and we'll answer them in the order that they are received.
All right, so is the mic on? I hope everyone can hear me. We're trying something a little bit new today. We're actually, with the question and answer, we're going to be videoing or broadcasting my face so you can see what I look like. And they can or cannot?
They can hear you from the microphone.
They can hear me from the mic. We just don't have video? All right, apparently we're going to get our video up and running, and then we do have at least one question from the audience that I'm going to be answering, and I can talk a little bit about the surgery as well. So we figured having a live feed of my video would be better. That way you guys could see me and see me answering questions. So we kind of have a dialogue going, you know, virtually. So I'm Dr. R. Deuk, and welcome to the Deuk Spine Institute's live broadcast of surgery from the Deuk Spine Institute and Surgery Center of Viera. We just finished up with a Deuk laser disc repair lumbar spine to treat 2 herniated and degenerated discs. I get questions all the time. Does the Deuk laser disc repair surgery work for degenerated disc disease? Yes, it does. This patient had degenerative disc disease, especially at L5-S1. It was really bad. There was 95% of the disc was degenerated and gone, dried out. But what was left was a little tear in the back of the disc in the posterior annulus that those of you saw. And in that tear, it's just a little rim of tissue, and that little bit of tissue is what was causing her pain. Now, when we tested the disc, we did a discogram. She ended up having or reporting 9 out of 10 pain, okay, at its worst. So at its peak, it was 9 out of 10. That disc is the cause of her pain because we asked her, was that the pain you typically feel every day? And she said, yes, it is. We call that kind of pain concordant pain. When we as doctors do a test on a patient and elicit a painful response, the pain can either be pain that they normally feel all the time, or it could be a type of pain that they don't normally feel. So if, for example, I punch somebody in their back today, right now, Sean, you want to stand up here? No, he's not volunteering. If I punch somebody right now in their back, I'm going to create pain in their back, but that's not their typical pain they get every day. So what we want to know when we're treating chronic pain is, are we nailing the pain source that causes that patient's back pain every day? Have we found it? And once we find it, we know the right way to treat it. So when it comes to pain from a disc, which is what this patient today had, 2 discs that were causing her pain, the real question is, where in the disc is the pain coming from? And what all the other spine doctors and surgeons around the world believe or don't believe is that the pain is coming from the slippage of the bones called spondylolisthesis, or it's coming from scoliosis, or it's coming, we don't know where it's coming from. But the reality is we've discovered where it's coming from here at Deuk Spine Institute. It's a revolutionary discovery. It's coming from the back of the disc in the annular tear. And so the Deuk laser disc repair procedure that you watched today is a surgery that's minimally invasive, endoscopic. It's outpatient, and there's no need to fuse bones. There's no need to put cages or bone graft or any kind of biological material in, okay? I can go in there and find the tear endoscopically, like we did with the endoscope. And once I've seen the tear, I know what needs to be done. It needs to be debrided. We need to clean it up using a laser. The laser is the best tool to clean up that tear. I've tried other tools before, like radio frequency probes. They don't work, not nearly as well. And of course, there's mechanical debridement using the pituitary rongeurs or a drill. Those don't work very well either. What works the best is the laser, by far. So that's the only tool I use, which is why the surgery always uses a laser, 100% of the time. So for this patient today that we just got through doing, you go back and look. She had pretty collapsed disc at L5-S1, not so collapsed at 4-5, maybe 50%. But it wasn't the collapsed disc that's causing her pain. It's actually the tear in the back of the disc. And I found both annular tears. We repaired them with the laser. So we do have a question from our audience. And by the way, if you want to ask me a question, feel free to. I'm happy to answer them. But our audience did ask a question. You want to read us the question, Sean? Sean is a little camera shy.
The viewer from YouTube is wondering, does granular tissue in the disc have a vascular aspect to it?
Oh. Can't get my animal crackers just yet. So does granulation tissue have a vascular aspect? The answer is yes. Granulation tissue is not something I've made up. It's actually a well-known part of healing, normal healing of tissues. So whenever a tissue in the human body, whether it's skin, connective tissue, pretty much every tissue that we have is injured, except for the brain, there is a process of healing. And that process of healing begins immediately with inflammation. Inflammation is a response of the body to damage, to an area of damage. And basically, inflammation is characterized by certain physiological and anatomical changes, chemical changes that occur in that area of damage. Most of it's mediated through what are called cytokines or interleukins, tissue factors. These are all small proteins that are released by endothelial cells in the damaged area or supportive cells like mast cells. They release these biologically active chemicals that stimulate or promote a response in that area called an inflammatory response. And the inflammatory response includes capillary vessels become leaky, the gap junctions between the endothelial cells open up and spread out, and it allows liquid from the blood system called plasma. It allows plasma to leak out into the tissues around the damaged area. You also have cells that come out, and those include macrophages, fibroblasts, and these cytokines or chemical intermediaries. There's many of them. We've only, in 2021, we've elucidated probably maybe 90% of them that are active in promoting inflammation by bringing in cells and causing cells to do things like release chemicals. Polymorphonucleosides are another type of cell, or otherwise known as neutrophils. So basically, you have this inflammatory response going on in the area of injured tissue because the cells in that area release chemicals that promote additional changes, okay? And you start to get in a growth of tissue called granulation tissue. And granulation tissue brings with it fibroblasts. Fibroblasts make collagen, basically scar tissue. They make collagen, elastin, and they promote healing in the area of inflammation. Macrophages come in and start cleaning up debris, dead tissue, dead cell tissue, dead connective tissue. They're just cleaning everything up, getting rid of the mess, okay? And then, of course, you have the ingrowth of nerves, new nerve fibers in granulation tissue, as well as new blood vessels. So it's the little nerve fibers, these tiny little nerve fibers that are growing, like little roots. You know, like when you have a plant that's starting to grow roots in the soil, and you look at the terminal root, and it's really thin and delicate, and then further up the root, it's more hard. It's got more chitin. Not chitin. I'm not sure what the material is. Maybe it is chitin. I'm not a plant specialist, but It's basically the material that thickens the walls of the cells that makes the root firmer, the further up towards the ground, the soil air interface. But further down in the soil, the roots are very delicate and thin. That's what these new nerves are like that grow into granulation tissue. They don't have myelin around them. They're not insulated. They don't have the material that provides them strength and support, and so they're just delicate little nerves that are pain fiber nerves. These are type C fibers, and so in the back of the disc where the annular tear is, once you've injured your annulus, you set up this inflammation, and there are two paths that can occur. Either the inflammation causes a healing of the annulus and all the granulation tissue goes away within a few weeks, and your pain goes away obviously right away. Or if the annulus is unable to heal properly, it sets up this cycle of repetitive inflammation, chronic inflammation that goes on and on and on for months and years, causing chronic back pain or neck pain, wherever the disc herniation is. And so what I do with the Deuk laser disc repair is I find that tear where that inflammation is going on, and I use the laser to clean up the tissues that are there that are causing the inflammation, most notably the interposed nucleus pulposus. That's the jelly in the center of the disc that's squeezed out through the annular tear and is promoting inflammation. So I use a laser to find that nuclear material, zap it away, and then clean up the annulus so that it's able to heal itself properly. So does granulation tissue have vascular aspect? I'm reading the question off the board. The answer is yes, it does. There are new blood vessels that grow into the granulation tissue. That's why it has a pink appearance, because it's full of little blood vessels.
We have another question from a viewer on Periscope who asks, how do you know that the structural deformity in this patient's spine won't cause more problems for them in the future?
How do I know? The question was, how do I know that the structural deformity of the spine won't cause more problems for the patient in the future? Great question. The answer is quite simple: experience. I have been treating these conditions of listhesis, scoliosis, stenosis, disc herniation now for 25 years of my career. And in 25 years, I've seen these conditions where they've been untreated and asymptomatic. It's very important. So a patient with listhesis, either it's anterolisthesis, retrolisthesis, or lateral listhesis, which causes scoliosis. So these deformities of the spine that do not cause symptoms in patients. In other words, patients with no pain, normal movement, normal motility, normal function, normal life, no restrictions, no symptoms, no nerve symptoms, no back pain symptoms, no neck pain symptoms, and they have these deformities. And so you have to scratch your head and wonder why. And so we all know about it as neurosurgeons, as spine surgeons. We all know there are patients with deformity of the spine that don't have symptoms, and we don't treat them. So everyone knows not to treat a patient that has deformity but no symptoms from the deformity. So I started to question, why are there patients with the same deformity who have no symptoms, and there are patients with the same deformity who have symptoms? And the answer became obvious. It's not the deformity. It's actually the disc. Next question.
Next question comes from YouTube. The viewer wonders, what kind of procedures and surgeries require intraoperative neuromonitoring?
Great question. So one of our viewers has said, what kind of procedures require intraoperative neuromonitoring? So the answer is, let's first talk about what intraoperative neuromonitoring is so everyone's on the same page. We have developed in medicine ways of monitoring the delicate structures that lie within the spine and around the spine, specifically the spinal cord and the nerve roots that come off the spinal cord. Now, nerves are a type of tissue that are highly specialized tissue, like muscle. Muscle contracts and moves your body. Nerves don't contract. They actually send electrical signals very efficiently from one place to another. So they're really like a cable that allows communication from one part of your body, one area of your body, let's say your brain, to other parts of your body, like the muscles in your legs, to allow you to move and walk. So nerves have the consistency of basically something like wet spaghetti. Okay, so after you cook spaghetti, it's really delicate. It's easy to break. If you push on it, just pinch it with your finger, you can push through the spaghetti. And so nerves are like that. If you push on them too hard, they break, they cut in half. And then you've lost that connection to wherever that nerve was going, whatever muscle or skin it was going to, or proprioceptive organ it's going to. Sometimes it goes to your anal sphincter, and then you lose control of your bowel, and you basically poop on yourself. Or it could go to your sphincter for your urethra, which is your controls peeing. And so you lose control of the ability to stop peeing, and you just go out of control. So these nerves are very important. They control muscles, and they also bring sensory information from what are called receptors, or specialized receptors that could tell you where your body is in space, proprioception. And without getting into too much detail, basically nerves are very important for communicating. So we have developed, when I say we, I mean collectively in medicine, we've developed ways of monitoring nerves and checking the integrity of the nerves, that they're actually functioning properly. And so it started with like EMG nerve conduction study tests that were done outpatient. The patient would lay on the table like an EKG. They would get a computer and wires connected to different parts of their arm or leg, whichever part you were checking the nerve integrity with. And you could run current through those nerves from one spot to the other through the skin using electrodes. And you could see if the nerves were working properly. And if they weren't working properly, there were some tests done on EMG, for example, that allow you to look at the muscles that the nerves go to that are not working properly and see if there are basically responses of the muscle. By sticking a needle into the muscle should respond a certain way when you stick a needle into it, okay? And if you see these abnormal waveforms, like sharp waves, for example, or triphasic waves, that tells you there's a problem with the muscle itself, okay? And that problem can either be a primary muscle problem or can be a problem with the innervation, the nerve supply to the muscle. So nerve monitoring during surgery, which is what this question is directed at, is really about asking me whether I monitor nerves for specific types of surgery and which ones I monitor for. Now, the choice of a spine surgeon to monitor nerves is an individual choice. There is no real standard that they have to monitor for certain things. What I can tell you is that every spine surgeon has a different opinion about when to use neuromonitoring in the operating room and when not to. And every different spine surgeon can choose different modalities to monitor. So the monitoring modalities we use are what are called motor evoked potential, somatosensory evoked potential, and EMG, electromyography. And basically EMG means that you're monitoring muscles for activity. So if I hit a nerve during surgery, I accidentally hit my sharp or hardened metal tool against a nerve, then that will send an electric current down the nerve to the muscle. And the technician sitting in the operating room monitoring the waveforms of the nerves throughout surgery will say, hey, I got some EMG activity in the left gastroc, which means that I hit the left S1 nerve root. I basically didn't damage it, but maybe just touched it. And that sent a signal down. So monitoring EMG, monitoring SSEP, somatosensory evoked potential, and monitoring motor evoked potentials during surgery is really an individual choice up to the surgeon. Now, for me, when I do fusion surgery with cervical fusion, front, back, or lumbar fusion, I do monitoring. That's because I'm putting implants in. okay? And I want to make sure when I put an implant like a screw in that I'm not hitting the nerve. And so that's why, because if you put a screw in and it hits the nerve or irritates the nerve, the technician will say, oh, hey, wait a second, we got some EMG activity. And then you could stimulate the screw and see if the nerve is actually getting activated through stimulating the screw. And it depends on the amperage. If you stimulate a screw and it activates below 10 milliamps, then your screw is probably touching the nerve. So you need to reposition the screw. If you stimulate a screw and the activation of the nerve is above, 12 milliamps or above, like 20, whatever, then your screw is far away from the nerve. So intraoperative monitoring is very useful. The problem is nobody wants to pay for it. The insurance companies don't pay for it. And so when they don't pay for it, that means I have to pay for it out of my pocket, and I'm not getting reimbursed for it. So it becomes a decision of like, well, who really needs intraoperative monitoring, and do I really want to spend the extra money on that? Because that makes it harder to cover my costs. It makes it harder to stay in business. It makes it harder to be able to treat patients. So I have to balance cost and need versus reimbursement. And insurance companies are always trying to underpay doctors and hospitals. That's why hospitals are closing. They're going out of business because they're being underpaid. So I don't want that to happen at Deuk Spine. I want us to be able to treat more patients, help more people. So to do that, we need money. And I usually do the monitoring on the fusions, and I pay for it out of my own pocket. We don't get reimbursed for it. We bill, but they won't pay us. They just deny it, and there's not much you can do to fight them. You can sue them, which we do, but that's expensive. It gets very expensive to sue insurance companies. You're looking at probably about $100,000 to $150,000 per surgery. And if the reimbursement I'm asking for is $150,000, basically the lawyer gets it all. So it's really an unfair system that we're existing in right now. It's not sustainable. I can tell you that right now. There needs to be reform, insurance company reform. So if there's anybody out there that can help make it happen, I can only make you aware of the problem, but insurance companies should not be able to deny paying medical bills that are reasonable and necessary. Yeah, that's my answer. So we use intraoperative neuromonitoring for fusion cases where I use implants. Other than that, I don't use it. Would I like to use it on every case? Absolutely. Is there money for it to be used on every case? No, there's not.
Right, and our last question comes from YouTube as well. The viewer asks, what did you see early on that made you decide to invest in laser spine surgery?
Yeah, great question. So someone said, what did I see early on that made me invest in the laser spine surgery? So great question. Great question. I trained at the University of Florida in Gainesville in neurosurgery. At the time I applied, it was the #1 training program in the country, along with Phoenix, Arizona, the Barrow Neurological Institute, and probably Seattle, Washington. Unfortunately, Seattle, Washington took a nosedive basically right after I got into UF in Gainesville for some Medicare billing discrepancies. So I won't go into that. But long story short, I was fortunate enough to go to a top neurosurgery training program in the country. And in Florida, there was a company called Laser Spine Institute. They went out of business about a year and a half ago. They're located in Tampa. And where I trained in Gainesville, it was about a 2-hour drive to Tampa. Gainesville being in kind of just north central Florida, and Tampa being a little bit off to the west side of Florida. So there was this place called Laser Spine Institute. They opened up in 2004, and when I was in my neurosurgery training, and early on, this is in 1997, 98, I really thought I was going to be a pediatric neurosurgeon and take out brain tumors from kids. I just thought that was the coolest thing in the world. Changed my mind a couple of years in, and then I thought I was going to be an epilepsy surgeon because I really liked treating patients with epilepsy. Excuse me. And then eventually I went and got interested in spine, mostly because spine wasn't really taken seriously, and there were not I had the ability to work with a surgeon named Jeff Henn, who I worked with several spine surgeons, Rick Fessler and Pat Jacob, and Glenn Rectine and Mike McMillan. These are all great spine surgeons, pioneers. But Jeff Henn really opened my eyes to the fact that spine surgery could cure pain in patients, and that the patients left the hospital within a few days and they were really happy. They were out of pain. And I was so impressed with how well the patients did with spine surgery, elective spine surgery for pain. I was so impressed at how well the patients did. And you got to understand, as a neurosurgeon, most of your patients have brain injuries, bad brain injuries, and they don't leave the hospital normal. They leave the hospital like paralyzed, stroke, can't move their arm, can't swallow, they need a feeding tube. It's horrible. So having that experience with Jeff Henn as a neurosurgery faculty, where we were operating on patients for back and neck pain and pinched nerves, and the patients were so happy afterwards, and they left normal from the hospital, that really made a huge impression on me. And it kind of basically solidified my interest in spine. So I spent the next 2 years just doing spine cases with Jeff Henn and other attendings. Any spine case I could do, I did it. Got really good at it. But there was this place, the Laser Spine Institute, and all the faculty at UF, they used to laugh at it, right? And of course we did too, because they laughed at it, and there are attendings. And they thought it was funny, it was a marketing gimmick. So we all grew up believing that that kind of surgery was just a joke. So one day I met somebody who said, how'd you like to watch endoscopic laser spine surgery? And I thought, please, you know. But before I said that, I really thought, well, you know, I'm not that busy right now. Would be kind of cool to go over there and see what they're doing, just so I can make fun of them. So I went and I watched the endoscopic surgery done, and I wasn't laughing. I was really actually impressed, very impressed. All of our surgeries on the spine required big incisions. That was not big, right? But that's probably the smallest one was that big. These guys were doing surgery with incisions that were 1/4 of that size. And the patients actually did well. So the whole idea of minimally invasive, real minimally invasive spine surgery, not the fake minimally invasive that we think, you know, that we're doing at UF, it really impressed me. And I learned from a doctor named Dr. Anthony Young out of Phoenix, Arizona. He was really a pioneer in endoscopic transforaminal surgery, so the kind of surgery we just did. But he didn't do an annular debridement. He just did a discectomy. And so a lot of his patients still had back pain. At the time, I was more interested in learning the technique, not really the results. So once I learned the technique and I could do it safely on my patients, I started doing it. This was back in 2006, I think, 2007. And so then I went and got more training overseas from Koreans in South Korea, German surgeon, English surgeon, Dr. King. The German surgeon was Dr. Sebastian Roten. The Korean surgeon was Dr. Sang-Ho Lee. He was the head of Woodydall Hospital for endoscopic surgery. Long story short, I went and sought out the best in the world, and I got trained by them. Okay, they agreed to train me. So I came back and started doing endoscopic surgery on my patients. And at first, I did it because it represented a new way, less invasive, possibly safer, with better patient satisfaction of getting rid of back pain, getting rid of neck pain, getting rid of arm and leg symptoms, radicular symptoms. And I wasn't as concerned about the results. I was more concerned about patient safety in the beginning and just making sure I didn't hurt my patients. And so After the first 30 cases I did, I realized that it's very safe as long as you adhere to certain rules and you follow them meticulously. And after I overcome that safety hump where I was really worried about safety complications, once I realized there were no complications and it was very safe, I started to really look at the results. And the results were amazing. It was better than any conventional surgery I had learned. And I went to a top program for training in the United States and the world. So I started to pay more attention to the patient outcomes and the results. And then I started collecting data and started to analyze it and then eventually published it. And the data we published showed 95% long-term elimination, cure, that is cure of chronic back pain or chronic neck pain after 6 years average follow-up. So that's a paper we're getting ready to publish. But long story short, that's how I got into endoscopic surgery. And like I said, initially I didn't believe it until I started to see it and do it and see the results. And that took several years for me to really be convinced it's an incredible technology. So I don't know if I answered the question. I think I did. But obviously the laser side, you ask about the laser. We have our own laser. We got tired of renting it, and the problem with renting the laser was that sometimes it wasn't available. And so we had to wait for the company to be available because they were using it elsewhere. So we invested in the laser. But as far as the technology, the surgery, why did I invest my time, my efforts, my career into learning and improving this technology about endoscopic laser surgery? That's the story I just gave you. I hope that helps. That was our last question, so we're done with this. We're going to be broadcasting the next surgery shortly. This next patient is having the same two discs that are problematic for him, left side pain and right side pain. So we're going to go on the left side and the right side. I can't remember which is which. We figure that out when we get in the operating room. I have to look at the consent form just to verify that. So I don't want to say the wrong thing. But we're going to make an incision on the left and an incision on the right. And we're going to fix the L4-5 and L5-S1 discs again. Those are the two most common that need to be fixed. And we're going to be treating his chronic back pain and leg symptoms.